started, we had only not more than 100 pediatric endocrinologists in the country, and the burden was huge. So there were thousands of cases of pediatric endocrinology were there, but then there were very few to cater them. So what we thought that there was a need somehow to have bridge in between them to develop special interest in pediatricians and physicians, and then they can really match and manage the overall case. Since then, there have been definite improvements which have happened, and now so many new things have happened. But this was what when I started in 2007 in that regards. So we started off and we realized that awareness was a major problem. So whenever we talk of a disorder, we know that there are three things: awareness, accessibility, and affordability. Now, everybody says it's affordability, especially when it comes to hormones. They're expensive, were difficult to get, but it's actually awareness. So we started with pediatricians' awareness. This was in 2012, and we can see many of the people who are still there. Many of the faculty is the same from that time. It's continuing from there. And then we conducted a number of programs across the country. We developed 6 modules, which are still the base of many of our courses. Till now, we have conducted 120 workshops, 15 practical pediatric endocrine courses across the country, and 5 advanced pediatric endocrine symposium. This is the 6th one that we conducted. So this was the first one in 2017, and we can see Dr. Hemchand here. So he was there right away at that point of time. Again, Dr. Hemchand talked about bone age. We discussed about this. Then there was a couple of year gap because of COVID. Since then, we have been having annual events every year. Every time we have got very good people coming from across the country. Now, after conducting so many programs, what we realize that once you conduct the program, people forget about that. Whatever you teach, they will just don't remember. And it is too much effort to go in terms of money, in terms of time, manpower, and everything. So we thought of using the power of social media to highlight that, and we set up this channel, which is now one of the largest channels as far as pediatric endocrinology is concerned. And it has been viewed across the globe. It provides, there are over 400 videos and everything on pediatric endocrinology. So anything and everything, it's available there. We then thought of in terms of systematic approach in terms of pediatric endocrinology learning. So we started off with our fellowship program in 2017. And as Dr. Ravindra was saying, that we are now recognized by the National Board of Examination. And it was in fact a dream for the last 10, 15 years that we were pushing for pediatric endocrinology fellowships, which were not available from NB. And now finally the dream has come, and BJ Vadia and our center is now the 2 centers which are going to provide training in pediatric endocrinology. Now, what we realize that even physical fellowships, many people who have done training and who are in practice or doing some medical education, they are unable to really come in for 2 years because it's very difficult for them to join and leave the practice. So we started with online learning in terms of medi classes followed by books. And then we thought if you want to empower people to develop applications so that they can use, and we discussed some of the innovations just recently. Our fellowship started in 2017, and both of them are here. Dr. Neha and Dr. Chetan, they started with the first program. Dr. Riddhi and Dr. Sajali was also there in the second group. Dr. Pratik is currently in UK. Dr. Sayan and Dr. Naveen are now pursuing DM courses in PGI Chandigarh and at AIMS Delhi. Dr. Manoj was here. As we can see, Dr. Vibha has joined with us as a consultant. Dhwani is currently in Patna, so we have people across the country. And we have got Dr. Alapan and Sandeep who are still there, who are working. And Dr. Nimisha is the last one to join. So we've got 13 people who have joined, and hopefully very soon we will have the National Board Accredited Fellowship, which will start here. Our learning portal provides validated tools for evaluation, assessment, and pediatric endocrinology, including a full fellowship in pediatric endocrinology. So we launched around 3 years ago, fellowship program in pediatric endocrinology, which was a very, I would say, a tough program. It has 2-year learning. Every 2 months, there are online exams. There are continuously lectures every week. Every 6 months, there is a 5 days program in which they come, they see a lot of patients, we discuss with them, and then this program happens. So there are 4 sessions which are there. We have developed a mobile application, which in fact is the most downloaded endocrinology app, and we talked about publications there. We are developing other tools like personalized intelligent EMR, which will help guide evaluation and management of pediatric endocrine disorders. We have developed BIG, the bone age assisted interpretation of growth, which recently Dr. Vibha was just talking about how it will help assess puberty, growth, bone age, and obesity at one single click. You will be able to get all the results. We are developing a personalized expert for nutrition in which it will analyze all your meal items in terms of lot of input which we don't know about glycemic load, all the other aspects, and then it will also provide based upon the requirement the recommended 7-day allowance. So automatic diet chart will come in for patients, which is coming up. We have already developed the Diabuddy app, which provides insulin dose guidance based upon glucose as well as carbohydrate counting, which is there inbuilt in the app. And this is being validated right away. So hopefully next time we would be launching it in a proper for a general use in that perspective. We have got number of books, basic, pediatric, and advanced. So we have tried to do a lot in this area over the last decade or so. Many of our efforts have been recognized. As I showed, Dr. Riddhi won the award for Best Bone Age Presentation at Kolkata, Dr. Sayan for Puberty Interpreter, Dr. Alapan at APES, Dr. Dhwani won the Kaichi Kida Award for the DSD Interpreter, Bone Age Assisted Interpretation for Growth, Dr. Vibha. Then also, so all of presentations have been there. There are a number of publications coming out of our tools, which have been validated and developed. So our fellowship in pediatric endocrinology, as I said, is a comprehensive one. There are over 100 modules, approximately 1,000 hours of videos that people have to watch. Pre-test, post-test, live lectures are there. There are on-site 4 visits with hands-on exposure. Assessments are done bi-monthly, 6-monthly, and an exit exam. And then there are other opportunities to collaborate in terms of research, learning, and teaching. So we have had multiple, we have now 9 on-site courses. This happens every 6 months. Started from 2019. To date, we have had all these on-site courses, and we can see many of the places which are here also. So this was the last course which was done just in June 25. And all of them, I think most of them are here. And this was the extensive program in which we had 300 patients coming from growth, puberty, thyroid, electrolyte, all the disorders. And they were discussed in intensive fashion. And discussion was there. So till now, 48 people have been awarded fellowships in this program. Ongoing 72 people are doing fellowship. There are many other courses also where people are enrolled. That number goes to thousands or something. 12 nationalities have been enrolled on that. So this is a way in which we are trying to increase the number of people who are working towards pediatric endocrinology. We all have been using growth hormone for a long time. The growth hormone the use was approximately 70 years ago. And since then, there were a lot of developments. And around 1984, recombinant growth hormone came in when the supply became unlimited. So there's a famous pediatric endocrinologist from US, Professor Rogol, who says that short stature became a disease when growth hormone became available. So it's not that the people were not short, but they were started pathologizing once we had the treatment, and then it expanded. So from there, it has been used a lot in kidney disease, Turner's, Prader-Willi, SG, and ISS. So this is something standard. Millions of children have been treated globally with good response and safety. But sometimes they can be problems. So this was a 12-year-old boy who had short stature. He had a height of 120, peak growth hormone was less. On growth hormone, he had a good initial response to growth hormone, but subsequently the growth velocity plummeted. Now we know there can be multiple causes like issues of other diagnosis, nutrition, hypothyroidism, sometimes antibody. But one of the big elephant in the house is adherence. Now, whether we have got a good adherence or not, which may be an issue, especially where it is being provided by the government or through some agency. Because if somebody is paying for themselves, this issue is not very important. But somebody is getting it for free, then the value becomes less. So this patient had low IGF-1 and adherence was considered. Now, if you look at adherence data, this was a wonderful study which was done in New Zealand, which clearly they really looked at how many vials of growth hormone was being returned and how many were taken. So it's not just the reported prevalence, they were actually measuring that. And what they found out when they rank low, medium, and high, you can see there is a linear correlation between the adherence and height velocity. So clearly adherence is important. And of course, if you give a daily injection versus a weekly injection, the chance of adherence will be much better in weekly. Dr. Rishi yesterday talked about weekly icodec. I talked about even monthly GLP-1 receptor agonists which have been there. So now we're talking about longer acting peptides, and why are we for growth hormone still using a daily injection is a question. So if you have a daily treatment, issues of adherence, you cannot change the time. If you miss a dose, what to do? Dropouts are more common, and then this may have a compromise effect from that perspective. So I'll talk about why, what, and how of long-acting growth hormone. So as I discussed, obviously less is always better. So we'll have less number of injection. It will be a safe therapy, efficacious therapy, but the question is whether it is accessible or not. So these are the questions we have to look at. We need something which is safe, effective, and we want also accessibility in that regards. So we have a lot of long-acting preparations. If you remember, GnRH analogs were initially given as daily injections. Then it came up as inhaled one. And then finally now we have got monthly, 3 monthly, yearly also have come up. So this is something which is there. Long-acting octreotide, we talk about hyperinsulinism. Now it's available, so it's much easier to give. GLP-1 receptor analog, earlier daily, then weekly. Now I'm talking about monthly also have come in. So these peptides are becoming there. And insulin, Dr. Rishi talked about this molecule, Icodec, which is to be given once a week. So definitely there is a move towards less frequent injections, which will going to be important from that regard to improve adherence, convenience, and quality of life. So there is a role of long-acting growth hormone. We need to understand how do we achieve that. So the options which are there to prolong the action is either to give us a depot. Like you give a Lupride depot, you give a concentrated one, and then you have a small amount of product which is released. It's not much change in terms of chemical structure. It's largely the preparation that is being changed. The other option is that if you bind this particular product to a product which has got a longer half-life, then it will stay there for a long time. Classical example would be something like Degludec, where you bind it with albumin, it will stay there for a longer time, the half-life will increase. The third mechanism is to add a moiety which has got a longer action. And when we talk about gonadotropins, we always say LH, FSH, and HCG. HCG has the longest duration of action. So if you link HCG part to the molecule, the action will become bigger and more longer in that perspective. And finally, there is the option of pegylation, which also increases that. So these are the 4 ways in which most peptides have been made into long-acting ones. Now, it's not that the long-acting growth hormone is new. We all know about eutropin depot, which was there, once a week preparation. I think it was there for 10-15 years. And basically, you give it, it's there, and it's slowly released in a controlled one. It's a depot preparation, weekly injection. But like Lupride depot, often we talk about sterile abscesses. This also had local complications. So currently, it's only available in Korea. It's no longer available in India. So this is something which was there. However, we do have data which has shown that this was a good drug, which had a good response, very similar to a daily growth hormone with a lot of safety data. So there is now evidence of over a decade which is there for long-acting growth hormone with the use of this particular molecule, which is eutropin. Another way of doing it, as I said, is to bind something else. So this is a CTP, the C-terminal peptide moiety of HCG, which is tagged to the growth hormone. So you have the same growth hormone on which the C-terminal peptide 3 amino acids are linked. It increases the half-life significantly. So this is a GH fusion protein, and this is the somatogron, which was developed by Opco Pharma, and now it is part of Pfizer. Half-life is 28 to 35 hours, and the dose you use is 0.66 milligram per kg per week. So it's a weekly preparation because you have bound CTP. There have been multiple studies which have been done with regards to long-acting growth hormone, and these studies have clearly shown to be as effective as the standard treatment, which is the daily growth hormone treatment. It's available in the form of 2 pens, 24 and 60 milligrams, and you can give it, and it's like any other insulin. You can keep it 2 to 8 degrees, use it for 28 days. The maximum dose that you can use is up to 30 milligrams. So this is how you can proceed from that perspective. Now, the studies which was done, this was the first study which actually had 224 individuals who were given somatogron versus somatropin, so both in equal arms, and this was screening randomization and a study which was done for a year. Now, what we see is that there is no difference at all in terms of the daily versus weekly. Now, these studies will, of course, focus on non-inferiority. They're not looking at superiority, but if you're as good, but the superiority is there, you're giving it once a week. That's good enough. So from all endpoints, across genders,
across growth hormone levels, this was found to be effective, and based upon that, it was given a FDA approval, then the European approval, and it is the only long-acting growth hormone which is currently approved in India. So this is something which we have been using also with quite efficacy. And if you see all parameters, you have got a similar scenario in that perspective. The adverse effect profile is also pretty similar. So it's a safe, effective, as safe and effective as daily growth hormone in that perspective. Other way, as I said, is to tag a molecule. So you tag something which increases the albumin binding. So somapacitan is a molecule which is developed by Novo Nordisk, in which it is tagged to a moiety which allows binding to albumin, increasing its half-life significantly. It's a linker one. The half-life becomes around 34 hours. So most long-acting growth hormone are 30 to 35 hours of half-life. And when you have 35 hours multiplied into 4, you have somewhere around 7 days. The dose is 0.16 milligram per kg per week. Remember, unlike growth hormone, where we say 25 microgram per kg or 50 microgram per kg, that's same for all preparations. Here, preparations are different. So you cannot say that, okay, this is 0.16, this is 0.66. The dose, of course, molecules are different. So you cannot compare that in that regard. So it has to be for every indication separately, available as 5, 10 and 15 milligram pens which are there. The study which led to its approval in the US was a real 4 trial, in which they had treated it for 52 weeks and then followed up with somapacitan to identify that. And what they found was that there was no significant difference between somapacitan and daily growth hormone in that perspective. So clearly, what we are observing is that both drugs are as effective as compared to the standard preparation of daily growth hormone. This is interesting of IGF-1, and I'll talk about that a bit later. There would be a bigger rise in IGF-1. So while daily growth hormone, it will remain more stable. For the long-acting, you may have a peak and trough. Peak and trough. So this is something when you're monitoring, you have to be bothered about that and concerned about that in that perspective. The pegylated compound, the lonapeg-somatropin, is a long-acting one, which basically is a prodrug which is bound by pegylation, and it is transiently pegylated and then removed. We know about erythropoietin and many other agents which are pegylated. So it's not a new technology. It's an old technology which is being used now. With this, half-life is around 25 hours, dose is 0.24. So it's 0.16, 0.24, 0.66. But then these are different compounds. So don't compare the dose per milligram basis in that regards. This is the one which comes as an auto-injector. The other ones are like pens, which are there, which are available. Now this study again, and this is one study which actually shows a better response. So this actually is a small study, but it does show that it does better compared to the daily growth hormone. And this is something which has been shown from that perspective. And overall, if you can see, the forest plot is going more in favor of long-acting growth hormone. But yes, it's a small study, so you can say it's at least non-inferior for all 3 studies in that regards. So if we compare the 3 products, currently we only have somatogron, which is available. It is addition of HCG moiety, dose is 0.66, pen device, and then you will need 2 injections if the weight is above 45 kg. Now this is important because if your weight is much higher, you cannot give anything beyond a 30 milligrams. So you will need a second injection here, and you can use basically within 28 days. Dosing window is 3 days. So if there is a gap, you can give within 3 days. So catch-up dose can be given. Somapacitan and lonapeg are not available, but they have similar profile. The upper limit is 50 and 60 kgs. And then again, you can use it for 42 hours. Lonapeg is, of course, a single injection. You have to use within 4 hours of that. So these are the 3 comparisons which are there in terms of that. And I'll recommend all of you to go ahead and look at this consensus statement on long-acting growth hormone, which is there. Importantly, Indian approval currently is only for somatogron at the moment. Now, if you compare the 3, you can see pretty much they are similar as far as height SDS and adverse effects. So pretty much at the moment, there's no head-to-head trial, but their cardinal studies are similar for both these agents in that perspective. So now to talk about a few practical aspects. Most of us do not have that much practical experience. So good that we have got a consensus guideline which will guide us about that. So what about this case? They want to shift to long-acting growth hormone. What should we do? So this has been published in JCEM just now, 2025. It talks about a lot of practical issues. There are issues which are unresolved, but they do talk about that. So they're saying which children should be given long-acting growth hormone. Of course, we would say at risk of poor adherence. So what they're saying is taking multiple medication, children living in two homes, children going for vacation. So these are all the indications, but pretty much they are more like a Western based recommendation. Our recommendation will, of course, be with regards to the cost. So the cost typically will be at least double what you're giving as a daily injection. So you have to be aware about that. So main in India would be the cost issue probably, which will be the consideration. Now, how do we start? So when they are switching, what they say is that you are giving daily growth hormone, you give it on the next day. So you don't have to worry, just start from the next day, long acting growth hormone. You can start off that. There is no catch up dose. If you are giving replacing from one to the other, which is not going to happen in India, then wait for 7 days. This is what they have recommended. Now, what happens is that this child has been shifted to long acting, but has missed a dose. Now, what can we do? That is the other question which will come on to that. So, what they say is that don't worry. If you have missed it by 2 to 3 days, no problems. It won't affect the efficacy. You can give it on that perspective, but try not to do that. This window is plus minus 2 days for somapacitan, for lonapeg, and plus minus 3 days for others. So roughly 2 to 3 days. So this will give you more flexibility. Suppose somebody is going somewhere for vacation for 3 days and the day is coming there. Don't worry, give it once you're back in the home. You don't need to carry that pen there. So this is something which is going to be another beneficial effect from that perspective. Very important issue is safety. Now, many people say that if you give a potent injection, levels will go up. And if the levels go up, whether there will be side effects or not. So on follow-up, the IGF-1 is plus 2.2 SDS. And we know we want to keep it below 2 SDS, preferably 0 SDS. This is what the aim is. Now, very important thing to remember is that when have you taken that IGF sample? We know that course is like that. So ideally it should be done on day 4. If you don't take it on day 4, you will say falsely high or falsely low. That is important. So this is something, if you do it, this is the profile, the levels will go up and come down. So if you take here, it will be low. If you take here, it will be low. So day 4 is when it is recommended to take the sample. And there are calculations which have been made. Okay, if you don't take on day 4, how do you correct it? Plus minus. So do the IGF-1 at day 4. So as you say, when you talk about 1000 milligrams of testosterone, you say take a trough sample. So you know when to assess the response. So therefore, day 4 IGF-1 is what is recommended. So now weight is 50 kgs. What do we do? I've already said that once the weight is above 45 kgs, the dose will be above 30 milligrams. You cannot use a single injection. So then you have to give 2 injections, and this can be a bit of a problem. Either, so it's not that you can make it like more frequent. Better is to give 2 injections. So this becomes a bit difficult to see how it happens. But then this is the issue to follow. 10-year-old girl with DHD, height is minus 2.4, but BMI is more. So obese children. Now we know in obesity, how do we calculate the dose of growth hormone? Whether we calculate per body weight or body surface area. European people were using body surface area because they were saying otherwise unnecessarily you are giving high dose. But here all the recommendations are based upon the body weight and not body surface area. So this is a controversial area. What to do? So what they have found that if you use dose which are very high, suppose somebody is 80 kg, then you're going to give a huge amount of growth hormone. So in that case, what they have said that consider in obese children, lower dose, or you can use ideal body weight to decide about the dose. So these are the 2 important considerations that they have given, and to avoid hyperglycemia, which has been reported on this scenario. Very importantly, if you give a high dose, of course, all the side effects, benign intracranial hypertension, slipped capital femoral epiphysis may happen. So other conditions where you have severe GHD, start with a lower dose. Now, many of us do start with 0.48 milligram per kg of somatogram. And sometimes we get good response and then we build up to 0.66. It is one of the cost issue. And second is sometimes you may get good response in somebody who has got a severe deficiency from that perspective. Now, 1-year-old boy with multiple pituitary hormone deficiency diagnosed in the neonatal period because of hypoglycemia. Now, whether this child can be shifted to long acting growth hormone is the question. He's on growth hormone, cortisol, thyroid. The problem with this is that LAGH may not be very, very effective in preventing this hypoglycemia. IGF-1 is high and low. So you may have trough period, you may develop hypoglycemia. So if a neonate has hypoglycemia because of GHD, do not use a long-acting growth hormone. 1 to 3 years, there's no study anyways. So most people won't use it, but avoid it, especially if there is a risk of hypoglycemia. So this is one indication. You should be careful about that. And if there is hypoglycemia, then you may increase the frequency. So you don't wait for 7 days, you make it 5 days. This is what is recommended. But I will say stick to the conventional daily growth hormone in that setting. Another question is a child with craniopharyngioma who is post-surgery, and in that scenario, the growth velocity is low, whether we can start growth hormone long-acting or not. Now, these children, we are worried about whether the malignancy can develop, whether IGF-1 goes high, it may be a problem. So at the moment, there is not much evidence to support the use of long-acting growth hormone clearly in this indication. 6-year-old girl with short stature, FSH was high, karyotype is XO. Turner syndrome, can we give long-acting growth hormone to this child? Now, studies, again, there are no data on non-GHD indications. So in India or even globally, there is no approval for long-acting growth hormone for non-GHD conditions. So I would summarize that we should use it beyond 3 years of age in GHD individuals who do not have a neoplastic pathology. So I think this will be the way to go forward. So I think to summarize, long-acting growth hormone has shown to be efficacious in terms of lesser injection, good safety, efficacy, but accessibility is a problem because cost is high. I'm sure with more products coming in, the cost will come down, as we have seen with other agents like GLP-1 receptor analog, GnRH agonist, and this would be a good way to go ahead in terms of therapy. And I'll conclude on that. Thank you.
Yes, thank you very much, sir, for updating us on growth hormone preparation. Yes, that is a need. If you really want a good result, compliance is going to be issue, and unless and until we are going to take care of compliance, we are not going to the expected results. But there are so many lacunas. Still, we have to wait and watch, particularly for non-GHD other recommendations. So still, we have to wait. And since there is only single brand which is approved and available in India, let us see how it is going to.
So definitely, just to finalize, cancer subjects, early childhood, non-GHD and obesity. 4 areas we are still not very clear, even globally.